Okay, everyone, we'll go ahead and get started. Welcome to Noon Conference today. We're very lucky to have Dr. Gustavo Heudebert to teach us about treatment of DVT and PTE. Dr. Heudebert, as many of you know, is the dean of our regional campus in Montgomery. But before that, he was here in Birmingham doing many jobs from program director to vice chair and is known as a beloved teacher and colleague to many here. He's been giving these lectures on VTE for as long as I've been at UAB, and I believe longer. And every year that he gives them, I learn something new, and I appreciate a nuance that I did not appreciate before. So this is the first time I will be hearing it via Zoom. So without further ado, I'll let Dr. Heudebert take over.
Can everybody hear me? Wonderful. So I'm appropriately barricaded behind the doors of my office here at UAB, and for purposes of the lecture, I will take off my mask. Everybody else, keep it on yourself. Rebecca, you too. And thank you, Ryan. This is my second or third time I'm doing Zoom lectures, usually to my South American colleagues down in my alma mater. So this might be my first English Zoom lecture altogether, and I certainly hope that Dr. Kramer learned something about it today as well. So let's get going, because I have a full deck of slides, some of which I'm gonna go quickly. And please, for those who, like Ryan and Carlos, who feel very comfortable with me, tell me if I'm going too fast so I can slow down the pace of the lecture. So we're going to talk briefly about the pathophysiology of clot formation. Those who know me understand that I cannot stay away from that. We'll spend most of the time talking on acute and chronic therapy for venous thromboembolic disease. And I have put a smattering of special topics because those are the ones that I usually get the most phone calls from the house staff. When should we use IVC filters? Should we treat SVTs? Should we treat distal DVTs? How about upper extremity DVT? Have things changes in the management of patients with malignancy and VTEs? In a topic that is complicated, I wish I could spend more time, but I already had too many slides about what to do with subsegmental PEs. I'll give you a little bit of the recommendation by ACCP and share some of the data. It's very controversial topic at this point. So this is the roadmap. We're going to talk a little bit of the coagulation cascade, not too much, so people, I know who is signing, so if I start talking about coagulation cascade and people disappeared, I will know who is leaving the conference. So I'll talk about briefly also mechanism of action of different drugs in the context of the coagulation cascade. Then I'll spend most of the talk about acute therapy and chronic therapy for venous thromboembolic disease, and then the special topics I mentioned before. So just to make Dr. Kramer happy, I have started the lecture with cases, 3 cases that I would like not to give an answer right now. We don't have an audience response system. Hopefully in the future we can even incorporate into Zoom lectures. But let me just talk read over the case. We have a 62-year-old gentleman that comes with the emergency department with pain below the right knee, and it's been going on for 3 days. No history of trauma, never had this before, no fever or chills. He has hypertension on just hydrochlorothiazide and takes an aspirin, probably for no good reason nowadays. He's afebrile and the vital signs are stable. His exam is normal, other than his right calf seems to be 1.5 centimeters larger in circumference than the left one, and there's tenderness to palpation. However, there's no warmth and no tenderness noted. Whole leg ultrasonography shows a 2-centimeter clot in the mid portion of the right peroneal vein. And these are your options. I can admit this patient and give him an enoxaparin 1 mg per kg every day, or 1 mg per kg twice a day. I can start a DOAC or a NOAC. I'm not gonna pick up a fight about which one you like it better. Repeat Doppler ultrasonography in 1 week and 2 weeks, or place an IVC filter. So that's question number one, and we'll go over the answers at the end of the lecture. Now, happens that after you talk to the patient and he has a really difficult time, especially nowadays, to return for ultrasound testing, you decide to start on a NOAC or a DOAC. The best that you can tell, he has no risk factors for bleeding. So he told you he's gonna call you back in 2 weeks to see how he's doing. You recommend which of the following regimens to treat long-term the DVT, in this case, the distal DVT. Oral NOAC for 6 weeks, oral NOAC for 3 months, oral NOAC for 6 months, or indefinite NOAC or DOAC. I'm gonna go back between those two names so everybody is happy. In the final case, we're gonna talk is a 67-year-old female that comes to the emergency department with a 5-day history of pain and swelling of the right leg that now has moved proximally to the thigh. Again, no fever or chills, not notice any redness. She does have COPD that requires home oxygen, and she carries as well a diagnosis of cor pulmonale. There's no other past medical history. She's actually been stable on her COPD. She's in a good regimen, including a LABA and a LAMA. She's a febrile, oxygen saturation is 97% on her 2 liters. There's distant breath sounds and prolonged expiration. The right eye is actually larger in circumference compared to the left. And not surprisingly, duplex ultrasonography shows a clot in the superior femoral vein. What will you do next? I'm gonna admit her and start oral either rivaroxaban or apixaban. I admit her and start oral dabigatran. I discharge her home in enoxaparin 1 milligram BID followed by warfarin. I discharge her home in oral dabigatran, or I discharge her home on oral rivaroxaban and apixaban. And we will see how you guys will have. Probably just write down your answers, and then we will compare to the ones I think are the right answers all together. Clot. How do we form clots? You know the Virchow trial. That's from all the way from the 19th century. You have to cut the combination of probably 2 of the 3 there. Some form of stasis, some form of hypercoagulability, and certainly probably, as in many, many cases, endothelial damage. And you see that as I go through the coagulation cascade. 80% has an identifiable cause of the DVT, and that's probably gonna get, that number is gonna be bigger and bigger, the same way that cryptogenic cirrhosis has almost ceased to exist, as we get better sense of what causes DVTs. And the reality is that usually there are multiple risk factors in one patient. And no, either they have a malignancy, they have been hospitalized, they're currently hospitalized, they have some form of immobility, some form of surgery, some form of infection, and certainly some hypercoagulable states. Now, to create a clot is actually complicated, and thank God we can clot, otherwise we would have died as a species several thousand years ago. So it took a while for the coagulation cascade to get formed and be fine-tuned. So we need it badly. So every cut that we have in life doesn't take us to death, but it's a complex interaction in between platelets and red blood cells that I'm gonna highlight in the following slides. This is an electron microscopy. You see this beautiful, delicate fibrin mesh that is surrounding red blood cells. That is exactly what happens when you have a cut. We want this, we really do, because otherwise we bleed forever. The problem is when you see this. Now this fine fibrin mesh has become this trap. And as you can imagine, this thing will not let blood flow go through it. Hence, you will get your DVT or your pulmonary embolism. This is a very well-formed, very well-structured fibrin, no longer mesh, that is trapping red blood cells. And if it doesn't get removed quickly, it will form a clot that is going to cause obstruction. That's what you're going to see under microscopy. And the patient will look something like this. So now you have, hopefully you will agree with me that this leg looks like has a problem, the left one. Otherwise, we need to send you back to medical school again. And this is a very obvious DVT. This is the one that you will not probably argue too much about. We deal with much more subtle cases, but this is what happens when flow is interrupted. So I think that the reason I'm putting this slide up, and unfortunately my mouse might not show here. Oh yes, you can see here. you need to have some kind of initial injury. And whatever that might be, because you are hypercoagulable, because you have trauma to the leg, something initiates what is called this is the initiation pathway. And the one thing that I want to look at, you got to look at is you need this vascular injury. You need a trigger for this to happen. But the important thing to see is eventually we form thrombin. And once you have formed thrombin, the propagation, the amplification of the pathway goes on. So everything, thrombin not only is a pathway to create fibrinogen and fibrin, which is this nice delicate mesh that we all need, but it also provides feedback. And I'm going to show you how this part of the cascade is the one that really propagates the thrombus. And to be quite honest, the really bad actor in both pathways is 10A. So as you can imagine, if we have a way that we can either attack thrombin or attack 10A, we can actually interrupt the cascade. Hence what the current drugs that we use, the direct thrombin inhibitors and the 10A inhibitors. This is probably a prettier depiction, but this is to also show you the pathways, how important is the amplification. It's very difficult to avoid this. So by the time clinically we see a patient with DVT, all this pathway of initiation has taken us all the way down to amplification. Once the platelets get involved in the song and dance here, it's very difficult to reverse the process. So and here are the areas in which we can attack. People are working on this tissue factor inhibitor. No good data on that. We sometimes use AT3 on patients who are AT3 deficient. It really nicely blocks 10A action on 5. Then this is activated protein C. Whatever you see, this is protein S, works as well. And you can see how powerful it is to inhibit a number of steps on the coagulation cascade. Hence, people with protein C and S deficiencies, especially the homozygous patients, get in trouble very early in life because there's no good regulation of the cascade when it's triggered for whatever reason. And I'm gonna stop there basically to say this element needs to be very much interactive, and the amplification piece allows us to come up with certain targets to stop the cascade to keep going. No more. And once again, this is good, and we'd like to keep it at this stage. We don't want people to bleed to death, and that's the delicate act of giving anticoagulants to patients, because this is interrupted to a certain extent when we anticoagulate our patients. A couple of slides just to tell you how the different medications that we have really interact with our natural procoagulants. So unfractionated heparin, unfortunately, is a large molecule that tends to unfortunately bind to certain plasma proteins, but its target is antithrombin. So it actually binds antithrombin, and actually also in this way gets activated factor 10A. It puts it together, binds it to the heparin, and all together, now that we have inhibited factor 10A, we can actually measure the action of unfractionated heparin through the PTT because 10A has been involved. Compare that to our much more sophisticated low molecular weight heparin or enoxaparin, which actually has a better fit with factor 10A. It's a perfect fit, but it's not a perfect fit for factor 10A. It misses a little bit of factor 10A, which is actually the one that we measure with APTT. So for us to measure activity of low molecular weight heparin, we actually have to measure activity against factor 10A. That's why APTT is not a reliable way to monitor for low molecular weight heparin. So this is my first stop. Clot formation requires an initial insult followed by sustaining stimuli. Factor 10A is central in both the initial generation of thrombin and the activation of platelets for further generation of thrombin. There are natural anticoagulants like heparin, and now we have basically molecularly based products like the DTIs and 10A inhibitors, and which are called man-made anticoagulants. Before I go to the talk, I think that we need to refresh the memory of terms that are important to remember when we talk about venous thromboembolic disease. We have people who have provoked, meaning has risk factor versus unprovoked. And the risk factors that you probably know very well are the transient major factors like surgery, immobilization greater than 3 days, having a C-section, transient minor, so surgeries that do not last too long, immobilization that do not last too long, being an OCP, so some form of estrogen. And then we have the persistent that are sometimes reversible and sometimes not. So malignancy, if we can get you off the malignancy pathway, it becomes reversible. Otherwise, it becomes sort of irreversible. Inflammatory bowel disease, if we have it under good control, becomes a reversible risk factor. And then we have the thrombophilia, so the severe heart failure patients that are always at risk for DVT, especially when you combine them with being needed for hospitalization. Site is important to talk between proximal and distal is defined as below popliteal, and that's going to have importance as we decide how long we treat patients or if we need to treat them. The final two terms are symptomatic versus asymptomatic. Some of the trials you're going to see are going to be related to symptomatic DVT. We have to stay away from trying to make decisions or trials on asymptomatic disease. And this is going to play a role about what to do with the subsegmental pulmonary embolism. So we'll have to talk a little bit about asymptomatic disease at one point or later. And then therapy is divided into three groups. Everybody gets initial therapy, everybody gets continuation on long-term, which is whatever is a finite period after initial. And then we're going to have a subset of patients that is going to require extended or indefinite therapy. So I'm going to be using these terms moving on. So acute therapy is actually not that complicated, and thank God is 85–90% of our patients we're going to be dealing with this slide. So thank God it's relatively straightforward and it's very much the same between PE and DVT. So that actually makes it simple. So we need to stop the clot propagation. As I told you, by the time we see the clot, we don't want more clot to be formed. This is not thrombolysis. This is actually stopping the amplification cascade of our coagulation system. And we have the heparins, we have the vitamin K antagonists, basically warfarin in the United States, and we have our DOACs and NOACs. There are other agents that are on the pipeline that I'm not gonna mention today because they are not FDA approved yet. Then we have ways to get directly at the clot, and I'll talk briefly about the role of attacking the clot directly, and we have mechanical ways to do it, and we have our friends in interventional radiology or surgery that can help us with that. And we have thrombolysis, and thrombolysis comes systemic, catheter-based, and catheter-based by ultrasonography, echoes machine. And then we have devices to impede migration of the clot. So this is basically operational for lower extremities DVTs. So as I mentioned before, the vast majority of patients is going to receive one of the following regimens: apixaban, rivaroxaban monotherapy, and I'll tell you in which cases that's okay to give entirely as an outpatient. If you're going to use edoxaban or dabigatran, you have to use low molecular weight heparin up front. There are no trials, I'm going to repeat this several times, there are no trials in which you can use upfront edoxaban or dabigatran PO. All of the trials have been done with upfront at least 5 days of low molecular weight heparin. In the United States, it's going to be enoxaparin. And you're going to see in italics in the smaller font, which probably is falling off use unless the patient has very good reasons not to be able to purchase the DOACs or NOACs. And that's the low molecular weight heparin followed by vitamin K antagonist. This is what the old people like me were trained under. And I'm gonna show a lot of the data today on the rationale of using this combination because it was studied back in the 90s, and I'm gonna stay in the 21st century worth of data for the most part. And under very unusual set of circumstances, You start upfront with unfractionated heparin. A good example would be you're going to plan thrombolysis, and then you have a choice to follow that with warfarin or a DOAC. Malignancy is changing. Malignancy used to be low molecular weight heparin followed by low molecular weight heparin, which is still the standard on pregnancy. But now in malignancy, you have the choices of low molecular weight heparin followed by edoxaban. That's probably the first NOAC DOAC that we had available. And now I'm going to review also the data on apixaban monotherapy for patients with malignancy. Let's see. Yeah. So quickly, if you're going to use unfractionated heparin, you have to give a bolus first. Same thing for low molecular weight heparin. This is last week is the first time I used fondaparinux in somebody who had HIT in the past. So now I can tell you that I've used fondaparinux once in my life at the VA. And you can actually use upfront a DOAC or apixaban or rivaroxaban. Once you know the patient has DVT or PE, you can either rebolus unfractionated heparin. You can just continue low molecular fonda or DOAC if the patient is eligible for upfront therapy with a DOAC. If you're going to use unfractionated heparin, HIT can settle very quickly, so you need to do daily platelet counts on a fractionated heparin. Low molecular weight heparin, to give you HIT, it takes a while. 3 days is fairly conservative, but that's the recommendation. Certainly, you're going to start seeing it by day 5 or later. If you're going to use warfarin, you start it on day 1, and then we'll try to define what long-term warfarin is. And once again, if you're going to use edoxaban or the bigatran, you have to use it after at least 5 days of low molecular weight heparin have already been provided to the patient. And let me finish with the thrombolysis piece. I know that Dr. McElwee does an excellent lecture on trying to decide when to risk stratify patients and how to deal with the pulmonary embolism patients. I have a slide from the European Society later on that hopefully gives you a little bit more information on how to make that decision. In patients with DVT, in reality, the only reason to use thrombolysis or perhaps some kind of mechanical approach is what is called phlegmatia ceruleus dolens. One of the great names in medicine is the big, swollen, blue cerulea, painful dolens leg. That's just massive, usually iliofemoral DVT. And other than that, in the DVT world, probably there's no indication. In patients with pulmonary embolism, thrombolysis remains probably the most utilized way to use it to attack these patients, certainly for patients with hemodynamic instability. And then we'll talk a little bit later on the high-risk stable patients. I know that Sam McElwee have talked about you guys in the summer about this sort of complicated topic. And a shout out, I already had too many slides, but there's now a paper in December of 2019 that have a look at the usefulness and the role that a pulmonary embolism team has on your hospital. And certainly looks like it decreases length of stay and decreases the number of patients who that get inappropriate therapy. So now some therapy coming out about the usefulness of a team that is the one that we have at UAB and is led by Dr. McElwee. So I'm going to show you what I call the 21st century slides. This is the first ever data that we have with a DOAC or a NOAC. So this is the bigatran compared to warfarin. This again, the bigatran started with low molecular weight heparin followed by the bigatran. Most of these were non-inferiority trials. 2,500 patients randomized, published in 2009. Clearly, no difference between the bigatran and warfarin in patients with VTEs. And interestingly enough, perhaps we're starting to see a little bit of a signal here that these DOACs and NOACs might be a little bit less complicated, safer to use compared to warfarin. Although at least on the bigatran trial, the incidence of what is called major bleeding. So the intracerebral hemorrhages, the retroperitoneal ones, the bleedings that require at least 2 units of blood and hospitalization. There didn't seem to be a whole lot of difference between the two of them. I'll make comments later on about other DOACs or NOACs that might actually have even a better profile than the Bigatran. So first trial is over a decade old now. And the next trial that came out was what is all this cute name, the Einstein investigators. Again, a non-inferiority trial. This is the acute component. I'm going to show later on the chronic component of the rivaroxaban trial, 3,500 patients or so. Again, it was not said to be a superiority trial, but clearly non-inferior rivaroxaban to enoxaparin. And just to finish up, this is the 3 years later, so the newer kid on the block, apixaban. Why they decided to include a small graph within the big graph, basically very low events rates when you use the apixaban compared to conventional therapy. Once again, enoxa followed by warfarin. So all the 3 NOACs have been studied in large randomized controlled trials. Again, the numbers keep going up. This was a 5,000 plus trial published in the New England Journal of Medicine. So over a period of 3.5 years, all the NOACs that we have available on the market have been studied and published and can be used in both pulmonary embolism and DVTs. Now, this is where we're starting to get perhaps a little bit signal in terms of which of the DOACs and NOACs might be preferred. Here, if you look at the major bleeding, this is not all bleeding, but major bleeding. Apixaban seemed to be better tolerated than warfarin. And although this is not the topic of today, apixaban might have a little bit of a better profile in GI bleeding amongst all the DOACs and NOACs altogether. It's still not completely settled issue, but this is the first that we had some real data based on RCT that apixaban, at least apixaban, seems to give less bleeding complications than a vitamin K antagonist. So to summarize acute therapy, therapy can be done either inpatient or outpatient for DVT and PE, and a huge caution with pulmonary embolism, because that probably have small trials that have been studied, but we don't have as much data as with DVT. And please, which I always remind the house staff, patients with poor cardiopulmonary reserve has systematically excluded from all these trials, both DVTs and PE. So your patient who had bad heart failure, your patient who have advanced COPD, small clots will kill them. So these patients, we tend to hospitalize and observe them because they can misbehave the first few days of therapy. Having said that, even in patients with poor cardiopulmonary reserve, after you got your first 2 to 3 days, which is probably the height of the risk if they're gonna have even a small emboli coming from the DVT or another PE, those are probably okay to discharge, but there's such a thing as patients that need to be hospitalized in spite of all the robust data on oral therapy with our NOACs. As I mentioned before, thrombolysis is indicated for patients who have phlegmatia ceruleus dolens, and certainly for hemodynamically unstable PTE. I'll be a little bit nuanced about that later on in terms of the subsets of patients who are quote unquote stable. And upfront oral monotherapy has been approved only for apixaban and rivaroxaban. Please do remember that. Chronic therapy has been simplified. I don't agree necessarily the way it has been simplified, but we'll talk about provoked, unprovoked, and recurrent. Those are the 3 subsets that we need to talk about in some special clinical circumstances. So this is one of my old quote-unquote data slides from a gentleman in Padua that has this wonderful research group, the Dr. Prandoni. And what he did is he decided to follow patients for a while. This is when we had very few choices and we were trying to decide which one was better, low molecular versus unfractionated heparin. So this patient got either one of those. All of them had a proximal DVT, or the vast majority of them. Everybody got at least 3 months of warfarin. And look at what happens when you stop. people who had a DVT will have a DVT or PE down the road. It's inevitable. Once you get it, you will have a recurrence sooner or later, even if you would treat it appropriately. And a fractionated followed by warfarin or low molecular weight heparin followed by warfarin is appropriate therapy. That really has not changed all that much in terms of the efficacy of that combination. So you have to tell your patients, the day I stop your medication after your first episode of DVT, be it 3 months, 6 months, 9 months, 12 months, I'll show you a little bit of that data, you will recur. It's a matter of time. So that's what makes it different to decide when to stop therapy for these patients who have actually, and again, this is DVT and PE. This is not, and this is proximal. This is not distal DVT. This is not upper extremity DVT. Those subjects probably have long-term risk, but we don't know that for a fact. So this is probably one of the first trials, what happens when you stop therapy. And I'm gonna show you that this trial actually randomized patients after 3 months. And shortly after 3 months, you can see how the curves start to differentiate out of each other. And then the trial was stopped at 24 months. And what happened after 24 months? Patients start to recur. So even if you prolong this trial probably until kingdom come, the day you stop it, people will start to recur again. It's uncanny. So please remember when you talk to your patients about, should I treat you for more than 3 months? And we're gonna talk about that in a second. Please remind them that if they are good candidates in terms of bleeding profile, probably taking therapy for a long time is not a bad idea. People have tried to say, okay, can I get away from using full dose anticoagulant, full dose meaning INRs of 2 to 3. So they have tried to give INRs to 1.5 to 2, doesn't work. Unfortunately, people have a 3 times higher risk of recurrence. So what is known today, and I have a little bit of stomach ache about it, heartburn, but I'll tell you why in a second. Up to 3 months is provoked reversible cause and first event. So the ankle injury patient that had a boot immobilizer. Actually, we have heterozygous APC resistance. So that's actually okay to give only for up to 3 months. And if you decide to try distal DVT, and we'll go over what are the pros and cons of doing so, you don't have to go beyond 3 months. Simple as that. Now, this is subtle language, but unprovoked VTE or provoked with irreversible risk factors is at least 3 months. So the language is a little bit different. It's not up to 3 months, it's at least 3 months. By the graph I told you, for me, will be considered indefinite because they will recur, but those patients need to have a low risk for bleeding. If they're on a VKA, they have to have a commitment to monitor. And if they are in a DTI or a 10A inhibitor, they need to understand that there is increased risk of bleeding, even if you bump it bad into a wall, if you take one of these drugs. But if they are excellent candidates, you have to sit down and decide, is it worth you to risk having a bleed, 1 to 2%, or a recurrence of what you had before, being a PE or a DVT? Unfortunately, it will come back regardless of how long you make it indefinite. And this is a very interesting data. These are people who completed actually 6 months of therapy, either VKA or apixaban, and then these patients were re-randomized to get either placebo, so all of them got upfront appropriate therapy, or 2 different doses of apixaban, exploring can we get away with lower dose of apixaban. And it's again, once and again, if you give them something, and actually works with warfarin as well, they do much better than if you give them placebo. And they actually keep a very low risk of recurrence in the 1% chance. And it doesn't matter if you give them 2.5 or 5 milligrams. So this is very reassuring in terms of efficacy, and also in terms of what are the risk of bleeding. the risk of bleeding on the apixaban arm of this study was identical to placebo. So the numbers were not high enough to decide if apixaban 5 is as safe as apixaban 2.5, but we know they're equally efficacious. So if you're going to go to long-term, apixaban at a lower dose might not be a bad idea. And the risk of bleeding seems to be very equivalent to that of placebo. Again, these are not huge numbers, but this is 2,500 patients that were studied. Finally, we have the same song and dance with rivaroxaban. So these patients, again, completed the trial with some kind of combination of upfront therapy. After 3 to 6 months of therapy, they get re-randomized to placebo or rivaroxaban. And once again, rivaroxaban stays on the 2% recurrence rate. And this is actually several years. Sorry, this is about a year after the trial was ended. People have tried to look at other choices that are perhaps less risky. This is showing you a study in 2012 in the New England Journal of Medicine. People, again, completed therapy with some form of combination of the above that we have mentioned before acutely, and then they were randomized to receive either placebo or aspirin. There are two slides. There are two graphs. It's graph A and graph B. I had to sacrifice graph B. This is a non-statistically significant difference. It approaches significance. It's a 25% reduction in the recurrence of VTE if you put them on just good old 80, this is either 81 or 100 milligrams of aspirin. But long and behold, if you add to this graph, which is graph B, all kinds of vascular events, it becomes statistically significant. So this gave us hope that perhaps aspirin is a good choice to follow conventional therapy, acute therapy. However, somebody decided to, not too long ago, to say, okay, aspirin sounds interesting, but let's see if I compare aspirin to rivaroxaban. And actually, I'm going to use rivaroxaban at the usual 20 milligram dose or even half the dose. And let's see if it behaves better or not than aspirin. And long and behold, seems to be that low dose NOAC, even compared to aspirin, makes a difference. So aspirin might be working better than placebo if you combine vascular events and VTE events, but upfront for VTE, low dose rivaroxaban seems to work better than aspirin. So puts us in a little bit of a conundrum. I think that if you're going to choose to extend therapy beyond the at least 3 months, both apixaban and rivaroxaban seem to be better choices than either aspirin or doing nothing. And then you have to decide with your patient the yin and the yang of taking longer therapy in terms of recurrences versus bleeding. Then we have the special group of the forever you're going to be on oral therapy. If you recur, you get forever. If you have an unusual site, mesenteric vein thrombosis, you host. If you have life-threatening BTE, that is a little bit under discussion. This is more wisdom and guidelines based. If you have homozygous APC resistance, that patient is going to recur for sure. And then you have the probably more exotic diagnoses, antiphospholipid antibody syndrome. Do not use DOACs and NOACs. Only VKA works for them. Same thing for mechanical valve, but that's not the reason for the lecture today. If you have ATT3 and protein CNS deficiencies, you're host for life. And something that I have not seen yet in my life causing DVTs or PEs, hyperhomocystinemia. This is the final, I just want you to remind you, this is again one of these old data sets. These are people who had a recurrence. Forget about the first characteristics of these patients. If you stop at 6 months, this is the recurrence rate after you have recur, is 20%. It's very, very high. And if you give him, in this case, warfarin, it's only 2.5%. Once you have recur, your chances for a further recurrence is astronomical. You have to treat these patients unless I suppose the risk of bleeding is prohibitive. This is the dosing of the DOACs. After you give in the 15 milligrams BID for 3 weeks with Riva, you get to 20 milligrams. Now, I have shown you data that perhaps 10 is okay once you completed the first part of therapy. And these are the doses for Apixa, Adoxa, and the Bigatran. And remember, the latter two always requires 5 days of upfront low molecular weight heparin. So summary for chronic, up to 3 months of therapy for unprovoked and at least 3 months for provoked. New anticoagulants are effective and probably safer. And I put apixaban there with a probably safer. Risk of recurrence is lifelong, just a matter of time. Once you recur and other conditions require lifelong therapy, aspirin seems to be an attractive strategy, but seems to be less effective, but safer. And at least in head-to-head comparison with rivaroxaban wins. Let's go quickly over this miscellaneous because I get a lot of questions about this. IVC filter as primary therapy, they're absolute contraindication for anticoagulation. You have to put a filter on those patients. Those are very sensible, intracerebral hemorrhage, huge major surgery. Now we have actually the retrievable one. So this, unfortunately, we don't do a good job to make it retrievable, but in theory, you can retrieve it after you have the planned and major surgery. If the platelet count is less than 50, so it's not any thrombocytopenia. If the patient has major trauma, for some reason have severe bleeding diathesis or active bleeding, you have to use this. And then you can choose it for relative contraindications. And you can see that. So thrombocytopenia less than 100,000, but over 50,000 is a relative contraindication. Interestingly enough, if somebody has a huge AAA and they cannot be repaired, and there's a chance that they will burst, if you give them anticoagulants, it doesn't look pretty. It's already awful to begin with. And IVC filter as adjunctive therapy, that actually we have robust data. If you give it a patient who to standard anticoagulation for whatever reason, they actually get a little less PEs, but they get much more DVTs as a trade-off, and there's no change in long-term outcomes in terms of mortality. So probably not indicated as an adjunctive therapy. And this one, probably some of my colleagues in pulmonary might disagree with me. People who had this huge pulmonary embolism that had either RV dysfunction, that are older, that had positive biomarkers. I'll talk a little bit about it. Should we slap a IVC filter in addition to whatever we do for them? There's a trial done by the French that say that it doesn't make a difference. There's no change in recurrent PE or mortality, but there's only one. It's a very well done study, but I think some people who have taken care of these patients in the ICU will feel differently. I will say that the best data will say that it doesn't work. Distal DVT, you have two choices. You can treat or you can take a look at them and see what happens to them. If you decide to observe them, has to be a combination of patient preferences. Say, no doc, I don't want to risk something that will make me bleed. Okay. If you do so, you probably have to tell them, let me take a look at that leg again in a week or two. So now you can see that the first question might have more than one right answer. And they have to be really no risk factors for extension. Those are not as well studied, and these are the risk factors for extension. You have done this before with a DVT or PE, so you're probably gonna extend again. You have persistent irreversible risk factors. You have malignancy that it seems to be that it's not responding to therapy. It's big and it's getting close to the proximal veins. If you have a positive D-dimer and if it's unprovoked. So those are things that you're gonna have to put all together, establish the risk of bleeding of your patient, tell them that they might have a little bit of phospholytic syndrome following this distal DVT. If they're young, they might not want to deal with that. So complex decision, not very good randomized control trial data, but enough information here that perhaps you can make an informed decision with your patients. This is something that we see in more and more. It's actually becoming very common. The last time I saw this in training, the patient had to have some kind of weird hypercoagulable disorder that I couldn't pronounce when I was a resident. And right now, it's actually courtesy of what we do on the upper extremities, midlines, PICC lines. This is what we are seeing this frequently. So a combination of a PICC line and a malignancy or a bad infection, well, we see that all the time in our settings. So what do you do for them? don't treat the ones below the elbow, and probably even those who are in the brachial vein don't need to be treated. Anything that is axillary or more proximal, those are the ones that are put you at risk for a PE. We don't have data for DOACs here, so we're stuck with the low molecular, the 20th century. I'm sure that we will have data sooner or later on DOACs. And how long should you treat it? If you remove the catheter, 3 months, like every other DVT. Otherwise, while the catheter is in place, which is usually, I'm going to be in the 6 weeks area. We don't use PICC lines much more than that. Finally, SVT, superficial vein thrombosis. You see this, it's a pretty painful and pretty easy to make diagnoses. These actually, people have these red streaks. They're very painful. It's not the whole leg, it's not the whole skin. It's just this very red, inflamed looking vein. If you have certain characteristics, as very long length, it's very close to the saphenopopliteal and saphenofemoral joints, that junction that maybe are going to extend to become a proximal DVT. This is the only time in which possibly 6 weeks suffice. This is not a DVT. It is not proximal or distal. Let me finish the talk with talking about malignancy. Until this trial, all the choices that we have was low molecular weight heparin. Warfarin does not work well on these patients. This is a trial in which comparing edoxaban to dalteparin, which is a very close cousin of low molecular weight heparin. This is what they use in Europe. No, this is a non-inferiority trial. We can use edoxaban. And then actually, this is just off press to 2020. It's as an EPUB publication in the New England Journal of Medicine. Apixaban compared to dalteparin, non-inferior, again, pure oral therapy. So now we have an oral NOAC that we can use for patients with malignancy. And this is actually very, very, very interesting. These are patients who have malignancies that are being treated with chemotherapy. Mostly malignancies that are known to be procoagulant, so adenocarcinomas, lymphomas. And these patients were placed on apixaban prophylactically versus placebo while they were in therapy. And they showed a statistically significant difference between VTE episodes on the apixaban group. So this might be patients that you might be starting to see patients who do not have a diagnosis of VTE, but have a malignancy on active therapy that might be coming to your clinic on a NOAC. Don't be surprised. There's some data that perhaps these patients do benefit. Not for every malignancy, but certainly the malignancies we know is associated with high risk for DVT. So summary for malignancies are multiple choices, and it's intriguing data on preventing VTE, and the only one that I have seen so far is related to apixaban. A word about hemodynamically unstable patients. This is from the European Society. So this is not recommendations by the US people, but I thought this was a very helpful table. People who have shock or hypotension, those are the easy ones. The European think that people who have RV dysfunction should be treated with some form of thrombolysis. So they put them in the same category. This is not something that everybody in the United States will agree with. And if you have cardiac biomarkers that are positive, BNPs or troponins, these are people who are in the question mark category. Species we talked about when we talk about diagnoses in the first lecture. If you have a high SPECI score or a PESI class that is high, that puts you perhaps in a higher category. Those are areas of question marks. And then you have the intermediate categories. This is where people have the most angst altogether. And they are divided into the high or the high risk or the low risk categories. And if you have no hypertension, but you have both RV dysfunction and positive cardiac markers, this is what some people are doing interventions, either catheter-based or systemic thrombolysis. I just wanted to show you this trial from New England Journal of Medicine 2014. These are intermediate risk PE patients. They got some form of TPA versus placebo. It was statistically different. The composite outcome was hemodynamic decompensation and death. It was that outcome, the combined outcome was statistically significant, but it was mostly related to hemodynamic decompensation, unfortunately, not to death, as you show in the table. And unfortunately, you have either stroke or intracerebral hemorrhage was 10 times more common in the TPA group, and it's 5 times more common to get major bleeding. So this is the angst about using some form of thrombolysis in these patients with intermediate risk pulmonary embolism. It might work, not improve mortality, and there's a price to be paid. Last slide, subsegmental PE. No RCT data to support or not therapy. Let me repeat that. No RCT data. A lot of strong opinions about this. The American College of Chest Physicians recommends against routine anticoagulation, which doesn't sit well with a lot of people, but that's the current recommendation. And there's one meta-analysis that they will be the first one to acknowledge that if the data is very heterogeneous, that supports the recommendations of not to treat based on the lack of evidence of mortality. There's a lot of retrospective data about patients who have been diagnosed with subsegmental PEs on staging for cancer, that if you treat them, they behave like treated patients that have symptomatic PE. A lot of discussions there. Up to date, if you read up to date and you don't read the ACCP that has like 175,000 pages to read, they will say the only people that you should not treat with subsegmental PE, either you have a single subsegmental clot / asymptomatic, and perhaps you have to have a negative ultrasound for DVT. Good luck, guys. It's common. I will say that I will agree that single subsegmental clot asymptomatic patient probably shouldn't be treated. People who have shown DVTs in the past and have something like a malignancy and you're staging them, that's a tough one not to treat. But if they have a malignancy in the GI tract and they got a bleed, probably I wouldn't treat it. So what should we do with the first patient? I think that we should start a DOAC as an outpatient. Or you can repeat a duplex ultrasonography. This is the distal DVT guy. You might want to have a good discussion. It's very reasonable to do one or the other in my mind. The second one is simple. If you're going to treat him, you treat him for 3 months. 6 weeks is not good enough for distal DVT. I think 6 months is too much for distal DVT, and you can get in trouble. You tell them to give indefinite DOACs. The last patient, this patient has poor cardiopulmonary reserve. This patient needs to be admitted, and then you have to decide: should I give him oral rivaroxaban and naltrexone for 2 to 3 days, then send him home? You should never, ever, ever, ever only use oral dabigatran or edoxaban. So that would have been a right choice. So acute therapy, very similar for DVT and PE. Duration of chronic therapy unclear for DVT and PE in my mind, indefinite if you have a good profile. DTIs and 10A inhibitors simplify chronic therapy. And this is Granada from a beautiful place, restaurant, looking at the Alcázar, La Alhambra, sorry, in there. So we have 3 minutes to spare, and I think there's a few questions here. Let's see.
So I'm going to let Dr. Heudebert look at the chat. We have some questions as we've gone through. We're about 3 minutes away from the 1 o'clock hour, so anyone that needs to log off, please do. I'm recording this and I'll upload it, so if anyone has to leave now but wants to see what the answer to the questions, you can always log on and see that later. So we may go past the 1 o'clock hour, but feel free to log off as you need to.
So Steve Alon asked, how do you define immobilization? I think that's people who are spending most of the day in bed. Yes, and the definition is high risk is greater than 3 days and low risk is less than 3 days. Calvin, Dr. Heudebert, are you familiar with any anatomical risk factors for DVT? I think that you have something like, there's somebody said about May-Turner syndrome. So when you have some aberrant veins that puts pressure on the iliac artery, that would be an example of a anatomic reason. Here said bifid femoral veins. I'm assuming that there's going to be a number of other anatomic abnormalities that I'm not aware of that put you at risk. Anything that perhaps causes stasis or compression, like in May-Turner, is going to get you in trouble. Jamie Caravaggio. Yes, I didn't put all the trials. So I did mention apixaban compared to low molecular weight heparin. I did not mention that there was a rivaroxaban trial for prophylaxis that was a negative trial. So the apixa for prophylaxis is a moving target. Let's see, this is for everyone. Calvin, I had once a patient with May-Turner or something like that, where the right femoral artery compressed, yeah. So correct. So there are some well-known anatomic abnormalities. Ben Taylor, to everyone, how does that trial with placebo go past 6 months? Which one, Ben? I'm sorry.
I think he was saying because the trial was so positive, showing recurrence rates were much higher. Why didn't the Data Safety Monitoring Board stop that trial early?
Good question, good observation. I agree with you. So Ryan, for everybody, so placebo 10% in first year recurrence, aspirin 5%, DOACs actually 1 to 2%. That's about right. So aspirin has an effect, DOACs have a greater effect altogether. So Carlos to El Jefe to everyone. So after first episode, recurrent 30% after stopping. Yeah, that's actually after many, many years, not immediately. So this is cumulative over time. Yeah, it's conceivable some patients prefer to take their chances. No, 30% for me is high. I will probably, if I will have a DVT now, I will probably choose I think my risk profile is very low. I would say that I will probably try to take it as long as I can.
Heudebert, one quick question. The data that you showed went out to 8 years and got up to about 30% at 8 years. Do we have any longer data than that? I mean, if you kept going with that graph, if you lived long enough, you would recur, but does it ever plateau?
I think that I'm going to look back at those graphs because I think that by that time it started to plateau. So it might be that 30% is about the risk, but I wouldn't be surprised that it's inching up a little bit over time. That's the best study that I've seen altogether. From Stuart, is upper extremity DVT distal to axillary vein? Do you weigh symptoms in your decision to treat? That's actually a very good point. Some of these patients might have the phlegmatia ceruleus Dolphin's equivalent, I suppose. Not that I'm suggesting that I would do thrombolysis for those patients. So clot burden might make you decide to treat. In terms of the risk of PE is very small. So that will be a slightly different decision that you might want to talk to the patient. Kevin, to everybody, my understanding is Rivaroxaban can also be used in malignancy-associated VTE. Yes, the answer is yes, not as prophylaxis, but yes as treatment. Yeah, the answer is yes, and Jamie put that as well. Jason Morris, off topic, but growing up, get lunch, guys. Free lunch, masks, safety, well said. At least until out 10 years, it continues to grow. 10 years for unprovoked. Yes, Stephen, that's what we know right now. These are usually the patients who are unprovoked, who are the ones that we know best, that are basically a lifetime risk of recurrence. Those are the questions that I saw in my chat dialog box. It's 102, 103, so thank you very much for your attention. Apologize for the deluge of data, but I couldn't include everything there, as you can see from the questions, but be safe, stay at home, social distancing plus mask, not just social distancing, and we will get through this, and we will enjoy face-to-face conferences shortly enough. Take care, everybody. Bye-bye.
Bye, everyone.